So following that inspiring, I'm now 5 times to apply for a CIHR grant. Congratulations. I'm inspired. I'm going to invite the speakers for the next session to come up and sit here at the front. So it's Dr. Shira Godenberg, Dr. Nancy Poole, and Dr. Indrani Margolin. And please join me in welcoming them. So this session, I'm delighted and honored to introduce you to the 3 speakers for the next session, which is entitled Marginalized Women's Health, BC Leading the Way. And as you listen to these highly esteemed researchers share with you their work, you will come to agree that BC is leading the way in the research of the health of women who live on our margins. And so each speaker will speak for 12 minutes, and there'll be time for maybe 1 question. We're on quite a tight timeline. And I will wave at a 2-minute point, but I think there is a stop clock here, so I'll just so that you see it, right? And then I'll be sort of facilitating the time. So first speaker is Dr. Shira Godenberg, and she is an assistant professor in the SFU Faculty of Health Sciences and a research scientist with the Gender and Sexual Health Initiative of the BC Centre for Excellence in HIV/AIDS. And today, Dr. Godenberg will be speaking about migration-related determinants of sexual health among marginalized women. So please join me in welcoming Dr. Godenberg.
Thank you very much. Such a pleasure to be here today. Sure, okay, great. So I'd like to begin just by giving everyone a bit of a foundation around some of the migration issues that I'll be discussing today and why I think this matters for women's health. So traditionally, migration has been seen as a determinant of health, largely from an epidemiological perspective, suggesting that when people are moving, there's potential for increased transmission of infectious diseases. However, I would argue, and I think many researchers today would argue, that this overlooks the social and structural determinants of health, particularly for marginalized populations who migrate. And in terms of the talk today, I'll be focusing on migrant women involved in the sex industry. Importantly, migration can also be health promoting. So we know that women, for example, often move for increased economic opportunities, to support children, to reunite with spouses, and these are all important sources of resilience and potentially improved health for women. And I would argue that marginalized groups, such as women who are involved in the sex industry, for example, sex workers, or people who use drugs, sexual and gender minorities, often experience increased inequities related to migration in terms of their health and social well-being. And importantly for today's talk, most prior research is focused on male migrants with a focus on occupational groups, for example, in the mining industry, agriculture, etc. So, and just in terms of thinking about time and directionality of associations, I just want to bring up that migration is, in some sense a linear process of moving from point A to point B, but it also can include, today I'll be speaking about mobile populations, and people can return to their places of origin. So there's very much a dynamic feedback loop, as you can see in this slide, and the determinants of health, both at the pre-migration, transit, and post-migration stage, include not only epidemiological concepts, such as the background level of, for example, HIV in a community in terms of background prevalence, but can also include things like one's legal status, access to healthcare in these various settings, employment and living conditions, etc. In terms of the links with sex work, we know that women represent half of migrants globally, and migrant women are overrepresented in precarious and insecure employment, including sex work, for reasons including gender inequities, discrimination, low recognition of foreign credentials, including, for example, women who might have degrees in areas even such as dentistry in their home countries. And I think not only thinking about this as something that people are doing due to a lack of options, but also because we hear from many women that sex work often offers a flexible and more high-paying opportunity that can allow them also to meet their children's needs and other priorities in their lives. And really important to today's talk is that historically there's been significant conflation of migrant sex work with the idea of trafficking. And so because of this has really impeded an evidence and rights-based response and has often resulted in criminalization and punitive environments that undermine migrant women's access to safe and supportive care. So today I'm going to be talking a lot about work from a longitudinal cohort called an Evaluation of Sex Workers' Health Access, or AISHA. This is a cohort that was initiated in 2005. by Kate Shannon, and it has been extended in 2010 with NIH funding to now, actually we have almost 1,000 women enrolled in the study across diverse venues across Metro Vancouver. It's very much community-based, directed by a CAB of over 15 agencies, and includes self-identified women, including trans-inclusive, aged 14 years and older. And for the study, we engage in significant street and venue-based mobile research and outreach, and of particular interest for the migrant population is really this is a major focus on indoor spaces such as massage parlors and other forms of venues that are often licensed as health enhancement centers. These are difficult to access venues, so our team spends a lot of time building rapport with community, engaging in regular outreach, including condom delivery, making referrals to sources of care within the community, and providing other sources of support, and engage in regular surveys every 6 months, as well as voluntary HIV, STI, and HCV testing and treatment where needed. Okay, there we go. So far this body of work has really shown that despite lower HIV and STI risks in relation to, for example, street-based women who are using drugs, we see, due to the context of criminalization and punitive immigration environments, really substantial and alarming gaps in care for migrant and immigrant women in sex work. We see barriers to condom access, low access to condoms in indoor spaces, as well as even barriers to antiretroviral therapy for those who are living also with HIV. For example, in a recent study on unmet health needs, we found that both recent immigration as well as longer-term immigration and increased interactions with police and police harassment were all linked to increased self-reported unmet health needs as well as limited access to justice. And just to contextualize some of this information, some of the quotes we hear from workers in these spaces include, we're afraid of letting strangers know about us. I don't want him, referring to their family doctor, to find out that I work in the sex trade, so I don't actively go for blood tests in general. Others say things like, the boss was afraid because this business isn't legal, so they don't support outsiders to come in and give supplies or to do blood tests. So really significant barriers to both community-based as well as public health outreach within these spaces, suggesting the importance of decriminalizing sex work as well as addressing some of the immigration-related barriers reported by women. In terms of other forms of oppression, such as ethnic and racial discrimination, as well as language barriers, we hear really frequent reports that this is felt to be really discriminatory practice in terms of which venues are targeted and how workers are interacted with. So workers and managers both report feeling that they're not treated equally as Canadians, and that they're very afraid of the police surveillance within their venues to then result in immigration-related proceedings that would result in a loss of their livelihood. And even more so, all of these barriers resulting in the fact that when violence is committed, for example, by clients, they're afraid to call police, which perpetuates a cycle of increased vulnerability to violence and unsafe working conditions. I'm also going to talk a little bit about a parallel line of work that I'm engaged in Mexico and Central America, and I won't have time today, but I'm also enthusiastic to speak with anybody who's interested about some work we're doing with refugee and migrant women in the Gulu region of northern Uganda, which is more of a conflict-affected population of migrant women. For today, I'll just speak briefly about some similar findings at the Mexico-Guatemala border based on a larger epidemiological study led by my colleague at UCSD, Kimberly Brower, as well as qualitative work that I led over the past few years on migration and women's health in this community, which is also based on significant local community partnerships and also complemented by a parallel line of research around ethics and how do we engage with migrant women in sex work, knowing this is a population that faces so many intersecting forms of oppression and unequal opportunity, and wanting to make sure that the research context is appropriately acknowledging of that and supporting improved care and not potentially perpetuating harm or any other unintended consequences. So that research on ethics, I think, has been really important in informing this work, both in Vancouver as well as internationally. So in Mexico and Central America, similar to Vancouver, but in a very heightened sense and a different context related to the violence context that's very much underpinned by the war on drugs in Central America. Gang and drug-related violence was probably the most important reason women were migrating to and as well as through this context, so being driven by their home countries because of gangs exploiting their business, being unable to make a living, or fearing for their lives. Intimate partner violence and childhood abuse were also important drivers, as were gendered power dynamics that simply limited women's labor market participation and caused them to go on the move to find opportunities elsewhere. And then we did hear about a number of cases of trafficking for sexual labor, so I think it's important to acknowledge that this does occur in some contexts, but that it's a minority of cases. The majority of the time when we're talking about people who are exchanging sex, we're talking about, when we use the term sex work, that's voluntary, and it's the exchange of sex between consenting adults for money. So just as an example of these intersecting and very gender drivers of migration and also of health in this context, as one participant in this study reported, "I'm from the capital of Honduras, and I came here because I had some economic issues. There's no work over there. I tried to be part of a gang, and I can't go back to my country because they're waiting to kill me. And I had other problems. When I was young, someone raped me, my dad died, and my home was a disaster. That's why I came here." So I think this really highlights also some of the challenges of trying to dissect these different sources of really inequity and poor health and susceptibility to violence that women in this context were reporting. So some of the findings from this body of work, again, really just speak to the intersections between health inequities, but more importantly, the broader human rights context that is faced by women who engage in sex work in this setting. So really, it's impossible to disentangle susceptibility to HIV, the reasons that women are using drugs, or barriers to healthcare access without appreciating the human rights context, which in this setting included even higher levels of police harassment and immigration-related concerns, very high levels of deportation and return migration following deportation in this context. So based on this body of work, myself and my colleagues at the Gender and Sexual Health Initiative and internationally have been working hard to advocate for evidence-based program and policy responses that address the intersections between not only sex work and HIV and STI vulnerability, but also the role that migration can play in that. And what this work has really talked about is, first of all, the importance of decriminalization as a strategy to remove barriers to health and the realization of human rights for women who choose to do sex work, as well as the importance of avoiding conflation of sex work or migrant labor with trafficking, which is a very distinct concept that requires an appropriate and ethically driven response. So, sex workers have long advocated for rights, not rescue. It's particularly concerning in the current Canadian context, where only a few years ago, despite much evidence that criminalization was harming sex workers, new legislation was imposed, which actually just criminalized new aspects of the industry, including clients, various aspects of indoor work, as well as third parties. So repealing those laws and replacing them, just repealing those laws really is what's needed to ensure sex workers' health, safety, and rights. So in terms of the interventions, I think that healthcare providers should be aware of. Mobile and community-based approaches are very much supported within the peer-reviewed evidence. Tailored sex worker-friendly services, ideally led by sex workers themselves, have been showed internationally, including in our Lancet review and other publications, to be an evidence-based practice that's recommended by the WHO, UNAIDS, and other organizations, as well as supporting safer work environments, addressing stigma, supporting sex workers to mobilize within their own communities, and addressing restrictive laws around sex work, immigration, and ensuring that interventions for migrants themselves are culturally tailored and multilingual. So with that, I'd just like to acknowledge the team that has been behind this work. We have an incredible team of experienced interviewers, staff who've contributed to this work, as well as community partners and investigators. So a big thanks to all of them.
For you. So yes, that was an amazing overview of the bulk of work that you've been doing. Very impressive. And we have time for one question. If anybody would like to ask a question, if you would go to the microphone to pose your question. No questions? Well, Dr. Godenberg, you're going to be here all day. You're going to respond to questions from the audience. Okay, I'll just get my script. So our next speaker is Dr. Nancy Poole, who is the Director of the Centre of Excellence for Women's Health and the Prevention Lead for the Canadian FASD Research Network. And today, Dr. Poole will be speaking with us about fetal alcohol spectrum disorder. So please join me in welcoming Dr. Poole. Thank you.
I was asked to speak. First of all, thanks so much to the WHRI for inviting me to speak today. So much appreciated. This section was meant to talk a little bit about BC leading the way, as you certainly saw in the last presentation. And I wanted to talk to you about a way of BC leading the way that I've been involved in the last decade, which is leading a virtual community of people across Canada who are interested in this issue of women's drinking and pregnancy and the prevention of birth defects and developmental disabilities that can result from that. And we've built this virtual community on a really slender lens of a 75-minute meeting once a month with lots of other connections in between in terms of developing research teams together, doing collaborative knowledge exchange, influencing policy and service provision, etc. And the whole network includes researchers, policy analysts, clinicians, community-based service providers, and birth mothers themselves in a collection of people achieving all these different things. And over this time, we've really had the opportunity to think through this concept of alcohol and pregnancy as being a much wider thing that many people have spoken so well today about, of how all these issues do fit together. And so really tried to pull it out to make prevention of fetal alcohol spectrum disorder a women's health issue and not just about alcohol and pregnancy. And, you know, we've been really helped along the way by having the birth mothers and advocates on the community level connected to us as we did the research and really helping us think through what's affecting their use and what's helpful in terms of supporting change. And it's allowed us to come together with this and make this framework together of all the things that need to be in place and in sync in order to really prevent fetal alcohol syndrome. That there needs to be awareness work at level 1, there needs to be discussion by service providers of all kinds at level 2. I'm going to talk mostly about the level 3 work, the specialized work with the most marginalized women and the women with the greatest substance use issues today. But also thinking that we don't quit working on prevention of fetal alcohol syndrome after the babies are born, but we really think about some of the intergenerational things and keep supporting. And always having in mind how important how our alcohol policies affect the ability to prevent fetal alcohol spectrum disorder. So this collective work has really allowed us to come up with all these amazing thoughts together. Now, I'm not going to talk a lot about the level 1 work, but I just wanted to mention that we've tried to help agencies and governments from across Canada do awareness work in ways that are not fetus-centric and are not exploitative. And here's a few examples of things we've done. You'll see that we didn't actually achieve that in the Ontario one there that has a naked woman with her womb pointing through the O and the implication that she doesn't love her children if she drinks in pregnancy. So we don't always win, but we do our best. We have come up with many other ways of talking about it, and this is something the Public Health Agency of Canada helped us do, which was to build this kind of harm reduction-oriented pamphlet circulated to all the Canada prenatal nutrition programs and Aboriginal Head Start programs in Canada that talks much more about small steps matter and come and talk here. It can be a struggle to slow down your drinking, and we're willing to talk about it here and not stigmatize here. We've also helped nurses create thinking about women's health and women's substance use much broader than only their use in pregnancy. And we're right at this moment just starting a project that is about catalyzing all those working with women in childbearing years to actually have discussions about alcohol, as well in general, as well as about the risks in pregnancy. And to do that in a way that's confident and competent, much like you were talking about, Josie, in terms of the motivational interviewing stance. So, but I wanted to mention the most marginalized women and this most marginalized topic of alcohol in pregnancy. I'm glad you stayed in the room, because many times when I come to talk about this, there's sort of a need to go to the washroom or do something else other than talk about alcohol in pregnancy. But I just wanted to honor the work of some of the programs across Canada that have really been thinking through this work of helping the most marginalized women get the help that they so richly deserve on these issues. And many of you will know about Shiway here in Vancouver, really a BC leading the way agency that has influenced people's ability to do harm reduction-oriented work and to be respectful of First Nations culture, to link women and families into a whole network of support on these issues. And I just can't say enough about how courageous and important this work was in BC and continues to be in BC. Another leading program in Canada that's part of this network is the Breaking the Cycle program in Toronto, who've done this amazing work thinking through what is it to bring developmental theory, attachment theory, historical trauma theory, and relational theory together to create this work with substance-using mothers. And to really, they have a wonderful way of talking about the fact that they work with mothers, they work with children, and they work with the mother-child unit. So really thinking about how do we build relationship and really connection together, and have done some great research such as this one that showed how important support and connection with service providers, as well as that mother-child connection, is in improving outcomes. A fabulous program in Winnipeg called the Mothering Project, who's really thought a lot about cultural work, trauma-informed work, low-threshold work, system navigation work, to really reach and retain and support women who are using substances in pregnancy, who are Indigenous in that city, and really focused on this idea of experiential wisdom as the key factor in that. And they're sort of slogan, I think, is very interesting there, that they're oriented towards kindness, which is something that a lot of women who use substances in pregnancy have not had the experience of receiving. We just finished a great evaluation with the Her Way Home program in Victoria, who are also part of this national network that we're leading, who have again underlined all these elements of relational, non-judgmental, harm reduction, outreach, having excellent staff, and doing community collaboration as fundamental to this work to prevent fetal alcohol spectrum disorder and improve women's and children's health overall amongst the most marginalized women. And we've summarized these things in various reports you can see on the Center of Excellence website. But I think one of the main things that's been kind of helpful about this national network led by us in BC is that we've been able to talk about what are the common elements in all these programs, as I'm sure you've seen in some of these slides, and put them together in ways that service providers can take to government funders and to others to sort of advocate for how we can bring this more sort of complex and less narrow approach to this work. I mentioned the postpartum support for new mothers, and there's some incredible programs happening across Canada and some great research being done here in BC on nurse family visiting, home visiting partnerships in the immediate postpartum period with marginalized women. So just really want to emphasize that that circle continues, and we don't just drop women the moment that they've given birth, that we continue to see the importance of holistic support with the most marginalized women. I just wanted to finish up by saying one of the ways we've been able to hold this network of people doing research, service provision, and knowledge translation, et cetera, together has been by using a blog. And you're more than welcome to follow us in this blog. But we've had a lot of fun, both leading the conversation in Canada and internationally. Just back from Australia, and they've been pressuring us to include things on our blog from some of the work that they're doing with Indigenous communities in the remote communities in rural Australia and Western Australia. So it's kind of fun to see people not only reading the blog, but asking to be a part of it internationally. We also do summarize the research by each year. For those of you who are interested, you can find an annotated bibliography of research in this area done around the world on the Canada FASD Research Network site. And just wanted to mention that, we have been able to publish a lot of different research in all different combinations of people in all different kinds of journals, whether they're program evaluation journals or addiction journals or whatever. And we really see the importance of bringing people together to write collaboratively and to get this discussion happening in more places than one. And I just want to finish up by saying I have an interest in the international level of this work, and invite you all, if you're interested, on Friday to come to the Listowel Hotel to hear Mary Lou McPhedran, a Canadian senator, talk a little bit about how this work is being discussed at the UN, and to launch a new book about gender inequity. Thanks so much.
Thank you very much, Dr. Poole. It was very encouraging to hear of the work nationally and internationally. We're opening it up for a question from the audience. If anybody would like to ask Dr. Poole about her work, if you'd come to the mic. No? Everybody's... Okay, Dr. Poole will be here, right? Yeah, for the rest of the day, so please do approach her. So, our third speaker in this session is Dr. Indrani Margolin, who is an associate professor in the School of Social Work at the University of Northern British Columbia. And Dr. Margolin will be speaking with us today on arts-based research for mental health, women finding voice. So please join me in welcoming Dr. Margolin to the podium. Thank you.
Hi, everyone. Thank you for having me to the WHRI, and Lori, I really appreciate being here. I'm really looking forward to speaking to you today about Dawn and I's work on older women and how they can find voice through arts-based research in their recovery from mental illness. Oh, yes. This? Okay. Yes. So, sorry, a little bit more about ourselves. So this was a CIHR-funded project, and Dawn and I both are at UNBC in the School of Social Work. So what we did is we looked at recovery through the eyes of those experiencing it. And we really wanted to understand how arts-based methods can help women make meaning of their experience, and if we could advance experiential and creative methodologies for these women who are experiencing a lot of social stigmatization and not having a lot of ways to articulate what it is they're experiencing and making meaning of it. So our overarching research question was, what are the recovery experiences of older women in the North experiencing mental illness. We did this to build upon a previous study at SFU out of the Center for Studies in Gender and Mental Health. We were part of a recovery and housing team, and this was a larger 6-year CIHR grant. And Dr. Marina Moreau and her colleagues did a scoping review around gender and social inequality in the recovery literature and found that women's voices are really missing. So that was really the foundation upon which we built this study. And I came into it through my work around knowing how arts-based methods can really help mobilize what's happening within an individual and make sense of that. So this was one aspect of a larger multi-site Canadian team where we looked at the recovery experiences of racialized women, older women, and younger women across Canada. And that's a book chapter coming out this summer with U of T Press around gender inequity and mental illness. For this particular project, these were the methods that we used. We focused on individual and group collages. We focused on creative movement and body gesture. And for the data collection, we used reflective conversations after each art activity to audio tape and transcribe what the participants were saying and understand the written work that way. And then we did member checking and specific reflections on housing and gender for our specific housing and gender team. So a little bit more about arts-based research. So these women are silenced and stigmatized based on their social locations of being women and their able-mindedness. And this has really kept them boxed in. What creativity does, and engaging in creativity, is that it forges within the self the power to deny internalized stigma and criticism of others. So we heard earlier self-stigma and social stigma and structural stigma. We're really starting right now at the self-stigma level, that internalized oppression, how arts-based research can really help women in the process of the research space, where lots of times they do feel that they are not in a power position, to help empower them and also find out what it is that is happening inside of them in this confusing experience. So the idea behind using a multimodal method of arts is you move from one art medium to another to help a person remain in their effective, intuitive space without coming back into the cognitive, reflective space. And that, in creating that space for a person, really helps them to make meaning and begin to forge connections of what is happening inside of them. And that's how the really deep insight comes. That's the power of arts-based research for in-depth qualitative work. So it can really capture insight that more traditional interview methods miss. So here was the criteria for locating our participants, and this is how we located them. We went to the Community Activity Centre, we went to the British Columbia Schizophrenia Society, CMHA, and other North networks. Northern Fire and North Network is a research center out of UNBC that I'm a part of the leadership team with, and we also use that space as a network to connect women across the North to get out information about health. So these are who the participants were. We had 7 women between 53 and 71. Most had children. All received some form of disability. They all had diagnoses, but they self-disclosed those. Those were not part of the criteria that they had to come with a formal diagnosis. They just ended up having a formal diagnosis. They could identify as having an illness. Important is that 2 were known peer advocates and on the Consumers Council, and several of them did have experience doing artwork, so they were comfortable in the medium. In terms of the analysis, we used 2 aspects. We decided to let the art speak for itself, which coincides with empowering therapeutic practice of the creator being the expert of what that artwork means, as compared to a psychoanalytical perspective where the expert is considered to be the person with the creator. So that in itself is a very empowering process that changes the power differential between researcher and researched. And the second data exploration we used was general qualitative thematic analysis by Braun and Clark from the reflective conversations we had between each arts process. So I'm just going to cover a little bit of the findings. I'm going to go a little bit more in depth because they're really interesting. We found that the women spoke about their recovery on a continuum from despair to hope. They talked about their extremes of experience, their anger and passion about stigma, and which went from joy and freedom in finding voice into supporting each other and through their advocacy activity. So this is a body movement. This is what one participant, you can see this is how she expressed how she felt at the beginning of her recovery, and this is how she feels in her recovery today. This is a collage that she did, and I'll just invite you to read that for a moment on your own. And here's a collage by Carol. This is my family. They loved me. When I wasn't easy to live with, the medical profession didn't know what was wrong. I come to that place where I would plan my suicide because I thought, I'm useless. I'm never going to get better. 6 years later, Carol finally got a diagnosis from a psychiatrist. You're bipolar. I got up and kissed her and hugged her. After that, I've grown, and out of it, I can give to others. And it's lovely, and it's wonderful. There's darkness, then creativity, happiness and creativity. And this was how she represented her experience from where she started to where she's at today. And creativity and advocacy was an important part of her getting from the left to the right. So this was a collage that they all did together, called Creative Heads, and some of the words on it are here, and I'll just invite you to read those on your own. The first was probably the most important message that they wanted us to advocate, that they're people first, and they have many, they're multifaceted, but they get treated like a mental illness. Thanks. In terms of the thematic, the themes, we found 2 overarching themes, toxicity and oppression, and paths to recovery and rejuvenation. So one participant talked about terrible sleeping conditions and how she really felt like she was being observed like an animal. Another participant talked about lack of sexual dignity and safety. The nurse says, get stripped and put this on, and you'll say, well, they're watching me. And she'll say, oh, well, they'll just close their eyes. So that was her experience at the hospital in the north. This participant talked about the stigma, people forgetting you're anything, like a mother, a nurse. This woman talked about her illness being overriding any other health issues. So she was actually having a heart attack, and it was overlooked because she had the blue band that signaled that she had a mental illness, and she was sent home. So I'm going to just move forward to pass to recovery and rejuvenation. And one woman said, you know, I found that body movement was painful for me because it just brings me back the darkness. But it's good because, you know, once you get it out, it's out there, like a spiritual release to feel free. This woman talked about the importance of holistic models being introduced to the medicine wheel and the importance of compassionate, empathic professionals. So what I'll end on is the significance of the arts. So the importance of these methods is that it's a really effective data collection method to inquire into in-depth experience. If anyone is considering methods that access more in-depth experience, I'd be happy to talk more about that with you. It's really a pleasant experience for everyone because it levels the playing field and everyone feels empowered in the process. And finally, being creative is essential to women's health. Being creative is really at the heart of moving forward in life in anything we do. We have to be creative even to have a thought, and we forget how important that is for our own health and other women's health. Thank you for listening. Here's my contact.
Thank you very much. That was a wonderful note to end on. Any a question for Dr. Margolin before we move to the next session? No? There's a question? Sorry, yes. Can you come to the mic? Yeah. Or you can come up here if you want. Thanks.
Hi, thank you for your great talk. You mentioned at the beginning that you had a couple of participants who were engaged in mental health work as peer support workers, I think. I wondered if you could elaborate on whether their journeys were different than those who were not engaged in our study on women with HIV. We have seen that women who are more engaged in the community, working at ASOs, et cetera, that is associated with different, better health outcomes.
Thank you for that question. I absolutely think that their engagement definitely fostered improvement in their experience because, number one, it took them out of their own isolation and it gave them worth and value for what they were doing, and they discovered their own expertise and knowledge in the process. I think what it really helped them to do was to articulate their experience, which was empowering in and of itself, which came out in our arts-based project. And I think out of this work, they worked hand in hand because this work really encouraged them to do more advocacy work. Yeah, thank you.
Hi, I'm delighted to hear that you are engaging patients as partners in your research versus participants, but could you maybe provide some insight on what your learning was as a researcher in engaging patients as partners?
Sure. So part of the learning was to listen, listen and listen more. In terms of research design, it was actually really helpful to have them lead some of the art sessions. So I would kind of mentor them through some of the group processes, but it really helped, I think, in making the other women feel comfortable, having peers lead some of the research processes. Yeah, it's not quite participatory action research, but it's somewhere in the middle because we're still driving the research. I think that it's the other piece that's really helpful that I forgot to mention is that we had 2 of the participants come with us to a conference and present from their own perspective. And I would advocate that where you can do that in research, it's really useful in helping speak to funders, speak to knowledge brokers, and really help the participants see that they really are the experts of this knowledge. They are the ones who are teaching us in many ways, and it really just honors them as women. And I think it actually, in terms of mental health, it does foster their own health in terms of what they can contribute to society and their community of women.
Thank you. Thank you very much. And so, whoops, we're coming apart here. Yes, it's the end, so it's okay. So just, again, thank you to our 3 esteemed speakers. It was a very informative session. And I think we're now moving right into the next session with Dr. Kate Shannon. Yes, thank you very much. Yeah, you can start introducing.